Today I'll be presenting a case of RAF mass. Mr. X, 45-year-old male, who's a farmer by occupation. He presented to us with the chief complaints of black-colored stools in 6 months, pain abdomen since 2 months, and palpable mass in the lower abdomen since 3 weeks. His history of presenting illness: the patient was apparently normal 6 months back when he noticed dark colored sticky stools, which was on and off for last 6 months, associated with normal colored stools in between. It was not foul smelling. It was but it was associated with altered bowel habits, like associated with loose stools at times, and also increased in frequency of stools, with 3 to 4 episodes of stools per day. He also gives history of pain abdomen, which is present since 2 months, on and off, dull aching type. It was not continuous, localized only to the right lower abdomen, no aggravating or relieving factors, not associated with food intake,
RIF
non-radiating. He also gives history of noticing a palpable mass for last 3 weeks, which was incidentally he noticed it, and it has not progressed since then, and it has been of the same size. No, he doesn't give history of any sudden increase or decrease in the size of the mass as well, and it is localized to the right lower abdomen. And he also gives history of generalized weakness, which he noticed since last 6 months. History of weight loss of almost 12 kgs in last 6 months. He gives history of loss of appetite since last 2 weeks. No history of fever, no history of any bleeding per rectum, no history of jaundice, no history of any urinary disturbances, no history of hemoptysis, chest pain, breathlessness, no history of back pain or any other bony pain. For these complaints, he consulted a local doctor where he was diagnosed 4 months back, where he was diagnosed to have anemia and was treated conservatively with medications for the same. Past history: he's a known case of hepatitis B, diagnosed 1.5 years back, for which he's not on any medications. No history of tuberculosis, no history of diabetes, mellitus, no history of hypertension, asthma, or epilepsy, no history of any previous hospitalization or any surgeries in the past, no history of any blood transfusion in the past. Personal history: appetite is reduced. He mixed diet. Bladder habits are regular. Powell has already described in the history of presenting illness. No history of alcohol or tobacco consumption. No history of any medication intake. Family history: he doesn't give any history that is significant to any malignancies in the family, in the first or second degree relatives. With this, I would like to summarize my history as a 44-year-old male patient presenting with melena, pain for 6 months, pain abdomen, and palpable mass since last 3 weeks in the right iliac fossa, with significant weight loss and loss of appetite.
Okay, from your history point of view, what's your differential diagnosis? Would you like to give a differential diagnosis or a diagnosis?
Yes. I would like to give a differential diagnosis at this point of time, since considering it has a 44-year-old male patient presenting with melena, pain abdomen, and a mass in the RAF. I would keep a differential diagnosis of 1, a malignancy arising from a right colon; 2nd, ileocecal tuberculosis. These would be the major diagnosis that I could think of at present.
Okay. So, what is the points against tuberculosis in your history?
He doesn't give any history of evening rise of temperature or history of any fever or any history of being treated for tuberculosis in the past, receiving ATT in the past, and that's it, ma'am. And had it been tuberculosis, he would have presented with generalized weakness and loss of appetite first before developing melena.
Okay, what is the typical change in, or what are the altered bowel habits in tuberculosis in contrast to malignancy?
In tuberculosis, it would be more of a systemic symptoms rather than a altered bowel habits that presents first. While in malignancy, it would have been GI symptoms that would present before the generalized symptoms.
In means relation to the constipation and diarrhea, I'm giving you a clue. So, how would tuberculosis present and how would malignancy present? So, in tuberculosis, more often there will be alternating constipation and diarrhea. Okay, so sometimes because of this strictures, okay, so they'll be having alternating constipation and diarrhea, whereas in malignancy it will be progressive increase in intensity of the altered bowel habits. So that is the difference, apart from the constitutional symptoms which you have already stated. Okay, so yeah, so tell me what is
bleeding also won't be there, no? Melina.
Melina may not be there. Okay, it can present with like bleeding, but it will be due to secondary strictures, fissures, that way. Okay, so IBD is one of the other differential diagnosis. Okay,
Yes.
So
Yes, ma'am.
that also can be given as one differential diagnosis. So Crohn's and ulcerative colitis. So whenever for that also, like you can ask additional symptoms. What all additional symptoms? Some things which you have missed in your history. Can you ask for IBD?
Or previous history of on and off pain abdomen. If he has developed.
Anything else? Extra intestinal manifestations of Crohn's and ulcerative?
Any joint pain or any small joint pain if he has the
skin manifestations, joint pains, all this can be asked for. Okay,
Yes.
Fine. So go to the first page. Yeah, you told you did you define Melina?
I just said black colored tarry stools, sticky tarry stools.
It's completed. Still black sticky tarry stool.
Tarry stools.
Anyone? Huh? Black sticky tarry stool which cannot be easily picked off. Okay. So, what is the minimum amount of bleed that is required to present as melina?
It should be at least more than 30 ml.
It will be 60. Okay.
Sorry, ma'am.
60. 60. Okay. So
yes.
Okay. Right. What is hematochezia? What is tenesmus? What is melina? You already defined. Okay. You tell me what is hematochezia?
Hematochezia is bright, frank blood that is present mixed with the stools.
Okay. And okay.
Tenesmus is mucus that is mixed along with the stools if the patient has.
No, tenesmus, any
pain, like it is painful or too difficult. And only passing. Ineffective, painful, urge to defecate. Almost always passing with the stool without, but it is painful.
Yeah.
Painful, ineffective. Painful, ineffective, urge to defecate.
Yeah. Straining to pass stool, it may or may not be associated with pain. Okay, so then what about so tell me, what are altered bowel habits?
Increased frequency of passing stools or constipation, loose stools associated with mucus discharge.
Does it have any definition for how many days in a week? For
constipation, 15 days of stool. And diarrhea more than three stools per day. Liquid consistency.
Yes. So persisting for how many weeks? Minimum of
Persisting.
so minimum of 5 to 6 weeks. Okay. Whatever diarrhea and constipation you told, no, that symptoms persisting for at least 5 to 6 weeks, you can call it as altered bowel health. Change in consistency, color, nature of stool, nature and frequency of the stool. Okay. So yeah. Next, okay. So for your first complaints are like through melena. So when will melena? When will they present with melena, Drishita?
If it is a malignant growth or anything, when it usually because of the bleeding from the tumor surface, it's usually in the upper GI symptoms or in the proximal colon.
Why will melena occur? What is the color? Black, no? So blackish brown. So why does it change to that color? What is responsible for it? Alteration in color?
The blood gets broken down into hemosiderin, which gives the black color.
Acid hematin.
Acid hematin gets mixed with it. Okay, so that's why it is changing into that color. Okay, so now lower abdomen. Okay, your pain is more in the right lower abdomen or left lower abdomen?
Right lower abdomen.
Right lower abdomen. So what all are the leave alone black colored stools? Okay, what are the differential diagnosis for pain in the right lower abdomen?
It can be either it can be benign causes or a malignant causes. And among the benign causes, it can be either inflammatory and non-inflammatory. Inflammatory can be either an appendicitis or a colitis, ileocecal tuberculosis, or inflammatory bowel disease can be the causes. And other non-inflammatory causes can even be intussusception or malignant causes like CA colon or a retroperitoneal mass, a cyst. These could be the various.
Okay. And something very common in young people, not in this age group. One differential diagnosis of right iliac fossa, pain or mass. Something related to
Appendicitis, or other than that, it could be
yeah, something which presents like appendicitis.
diverticulitis, torsion.
Something related to lymph nodes.
Mesenteric lymphadenitis.
That's more like commonly given diagnosis, no? It's like in when that comes to appendicitis or mesenteric lymphadenitis is the most common diagnosis they give off. Okay, so in most often young people. Okay, rather than this age, it's more common in young. Okay, so yeah, next page. Okay. So what is referred to? What is radiating pain?
Radiating pain when the pain is pain and the distant area are anatomically connected. That is a radiating pain. When the referred pain is the origin of the pain and the secondary site are not anatomically connected.
Okay. And it starts in one place and is referred to other place of origin, anatomically connected. Oh, okay, fine. Then what is significant weight loss?
Loss of weight of more than 10% in 6 months or more than 5% in 1 month is a significant weight loss.
Okay. And okay, next. Anything, something important, you told patient takes mixed diet. Okay.
Yes, ma'am. Yes,
So
ma'am.
when it is right ilia fossa, one of the differential diagnosis, you can specify about fiber, red meat. Okay. So
Yes,
that is something you can always specify. Smoking or see tobacco consumption in any form. Okay. More so, it's this is related to smoking, right? So all the colorectal malignancies are more common with smoking. So you can
is associated with increased risk.
Okay, and over how much time duration that ulcerative colitis can present with colorectal cancer?
It usually takes close to 10 to 15 years for it to develop.
Approximately 20 years. Okay. So
its relative risk is 8 kya? 8 times?
I think 8, I think 10 times, but I'm not sure of numerical. But it's 10 times. Crohn's has less relative risk than ulcerative colitis. I think what you're telling is Crohn's. Ulcerative colitis has more risk, but just check it. I'm not aware. I don't remember here how much risk. Okay. And ulcerative colitis, is smoking protective or is it risk factor?
Smoking is a protective factor for ulcerative colitis.
Okay. So, okay. You asked about hepatitis B. Any relation to this case, or it's just like because he was Hep B positive?
No, the patient was hepatitis B positive. He gave me that history.
Mm-hmm.
Other than that, if he is immunosuppressed, if he was on any medications, if he was in immunosuppressive status, then tuberculosis also would come into a picture. So that's why I wanted to know about the medications history as well.
Yeah. So viral infections, viral lymphadenitis, all this can be one differential diagnosis. So they can. What is the cause of mesenteric lymphadenitis? What's the main organ? Do you remember?
No, ma'am.
Yersinia enterocolitis. Okay. So, okay, you asked about family history. Tell me something really about family history and colorectal cancer. What all were in your mind?
Family history to know any first degree relative or second degree relative with colon cancer, or any relative who had developed colon cancer before the age of 50 years, or any history of other breast, ovary, or other diseases among the female first degree relatives, to rule out hereditary BRCA2 mutations or any in this, and also to find out if there is any Lynch association in the family.
So, in family history, the more you're more concerned about polyps, right?
Yes, ma'am.
So,
and polyp.
So, tell me what are the criteria? What is the name of the criteria which states about polyposis as well as colorectal cancers?
So there's Amsterdam criteria for Lynch syndrome diagnosis.
Amsterdam and Bethesda, right?
Bethesda for genetic testing in case of these colorectal cancers.
Yes. Do you know the components?
In Amsterdam, there should be at least 3 first degree relatives associated with colorectal cancer, out of which 2 should be two successive generations should be affected. FAP should be excluded, and they're associated with other Lynch associated. If the first degree history of any other Lynch associated malignancies as well, and
so 3 members should be affected. 2 should be successive generation. 1 should be first degree relative, diagnosed at less than 50 years of age, FAP exclude, and histologically confirmed, histopathological verification. Okay. So, what about this one, Bethesda?
Bethesda is all the criteria of Amsterdam criteria should be fulfilled. One. Second, there should patient should be diagnosed with colorectal cancer before the age of 50 years. In that, and polyps more than 100. And I'm not aware, there are two more.
Colorectal cancer below age of 50 years, correct. Something related to synchronous or metachronous colorectal cancers or HP?
अभी तो all diagnosed cancer patients should go for MSI testing. So still we have to tell this criteria.
No, it's not like that, but they might ask you because these are related. No, say polyp discussion will be there whenever you're presenting some colorectal cancers. So they'll ask you what is about MSI. They'll ask you about Bethesda. They'll ask you about Amsterdam. Okay. What are the other polyposis syndromes? What is FAP? What is HNPCC? What is attenuated FAP? All these are like questions. Okay. So
because this criteria is to decide we have to do testing or not ना. Now we are doing to all diagnosed patient. तो मैं ऐसा exam point of view पर सोचा था कि now they won't ask this criteria because अभी तो सबका कराना है ना.
They'll ask. All timers will ask, and most of the examiners are full. Okay. So now it is there. Everybody should get tested, but they will ask criteria. So it is easy only, not difficult to remember. Okay. So colorectal cancer less than 50 years of age. Okay. Synchronous or metachronous colorectal cancer at any age. And if it is MSI, it should be less than 60 years. Okay. And one first degree relative, more than one first degree relative if less than 50 years of age, and more than two first degree relatives at any age. Okay. So first degree relative, two relatives with colorectal cancer at any age. Personal history of colorectal cancers at less than 50 years. These three as per age. Or synchronous metachronous cancers and MSI high with less than 60. These are Bethesda criteria. Okay. So, what is the most common hereditary colorectal cancer syndrome?
Lynch is more common.
Okay. What are the components of Lynch?
Lynch syndrome includes colorectal cancer, pancreatic cancer, stomach, upper urinary tract, ovary and uterus, prostate.
Okay. So what is the incidence of Lynch syndrome in colorectal cancer? I mean, how much percentage?
So hereditary cancers in colorectal is 10 to 15%. Among these 10 to 15%, Lynch accounts for almost 20%. 20 to 30.
I think it is 3 to 5% of colorectal cancers have Lynch syndrome. Just check, okay?
Yes.
And how many percent have endometrial cancer in this Lynch syndrome?
Lynch 60% is associated with the endometrium. So endometrium is more commoner than the colorectal.
Endometrium is most common extracolonic, I think.
Yeah, extracolonic. So in Lynch syndrome, most common is colorectal only. In extra colorectal cancers, it is endometrial. Okay, it is less than 5%, but just check it. Okay. Then okay, Lynch is autosomal dominant, recessive.
Autosomal dominant.
Dominant. Okay. So what are the genes associated with this?
MLH1, MSH2, MSH6, and PMS2.
Correct. Okay. So among this, most common is?
Most common is for colorectal, it is MLH1. Next is MSH2.
Yeah. What endometrial?
For endometrium, it is MSH2 is more common.
And
6 and PSM.
MSH2, MSH6 and PMS2. Okay.
Yes. Yes.
And what about yeah? So what are mismatch repair genes, Drishita?
So mismatch repair genes lead to formation of mismatch proteins, which are responsible for any usually there is microsatellites in the genes which are more prone for mutations, and whenever these mutations are there, these are corrected by these mismatch repair proteins. So whenever there is deficiency of these defect in this mismatch repair proteins, there is increase in microsatellite instability.
थोड़ा confusion है इधर मुझे लगता है. I think microsatellites make MMR proteins. These MMR proteins repair the single strand nucleotide repairs. No? Am I wrong? Wrong? I think
MMR genes are there which produce MMR proteins.
Macrosatellites are the places where most of the changes happen.
Microsatellites are prone for mutations.
And
they're short repetitive.
And this MSI is helping in the base excision repair, single base को repair करने.
That's what they help in repair by what? They form the MMR. This
they form the homodimerization of जो इन्होंने दो proteins के नाम ले रहे because they work in by forming.
They work in pairs.
Dimerization.
That's what they form the protein, or they are
It is MMR genes which produce MMR proteins. It's the same name.
Yeah.
What is MSI then?
MSI is a microsatellite.
Instability. So generally there are microsatellites. If there is instability, MMR will repair it if it is not deficient.
Okay.
Yeah. Okay.
So what is MSI high, MSI low, and MSI stable? Or MSS?
So when there is a defect in these MMR proteins, there's increase in the instability among the microsatellites. So these are considered microsatellite high, MSI high. When the MMR proteins are intact, it is MSS, microsatellite stable.
Two things is there. Protein के लिए अलग terminology है, genes के लिए अलग terminology है. Proteins, proteins is we are using detecting in IHC, and for genes we are detecting by PCR or NGS. So उसमें deficient बोलने के लिए हमको वो word proteins के लिए use करना है, genes के लिए use नहीं करना, I think.
So 5 use करते हैं ना. Out of 5, if there are 2 or more than 2 mutated, then MSI high. If 1, MSI low. If 0, then stable. Or percentage 30%. If it is more than 30%, then MSI high.
So loss of protein you will find in IHC, and this percentage you will detect in PCR.
It's through NGS. MSI is through NGS. MMR is through IHC.
IHC, yes.
So
I think it is way around. MSI we detect by IHC, and for direct detection of any deficiency or mutation in the genes, which is known as MMR deficient genes, that is for genetic testing or NGS.
MSI
NGS.
Okay.
This is madam is correct.
So what is the age group in which Lynch syndrome occurs, Drishita?
Lynch syndrome is usually around 35 to 40 years of age group.
Okay.
Or so 20, about 25, or it is 5. So that's why the screening is started 5 to 10 years before the youngest relative is being diagnosed in case of Lynch.
In FAP?
In FAP, they say the process of malignancy change occurs when the patient is in the high school, roughly around 16 years of age.
I think FAP is 20 and Lynch is 30.
FAP is 10 to 12 and Lynch is 20 to 25.
Screening, na? What the age of diagnosis of disease?
Diagnosis of FAP is usually they say the changes start when the patient is in the high school. So, and develops malignancy somewhere between 16 to 20 years of age.
What I remember is 39 FAP, 49 HNPCC.
By 40 years of age, everyone, it's 100% penetrate. So, by 40 years of age, everyone will develop malignancy, and screening starts in FAP by
10 to 12 years.
10 to 11 years.
Yeah. Because the carcinogenesis changes start at that age. By the age of 40, almost everyone is detected with colorectal cancer. Okay? So, okay. Then, yeah. So, more than 30, what he told is correct. Okay? MSI, expression of sequences. Okay? Nucleotide sequences. So, what about, yeah. So, FAP, can you tell me something about FAP, HNPCC? FAP, attenuated, Drishita?
Yes, ma'am. Yes, ma'am.
Yeah. Tell me something about FAP. Age of detection? How many polyps?
Usually, FAP is associated with multiple polyps in the colon, as well as it's also associated with the duodenal polyps as well. Other than that, it is associated with the desmoid tumors, osteomas, epidermal cyst, and the genetic being the defect in the 5q gene, APC gene, and autosomal dominant. And in colon, it is associated with polyps more than 100. More than 100 polyps are usually present, and they.
Okay. So you told variants of FAP, Gardner, Starkotts.
Yes, ma'am.
Okay, fine. What is the gene?
There is attenuated polyp, where the number of polyps is between 10 to 100.
And what is a gene in FAP?
5q APC gene.
Okay, fine. So, what about any other syndromes, you know? Hereditary, familial, colorectal cancer syndrome.
Other than this, there are those MUYTH polyposis syndrome and Muir-Torre syndrome, which is a variant, Gardner-Coats, and then even BRCA mutations are also associated. Banyan-Ruvalcaba and Cowden syndrome. PTN syndrome.
Hereditary breast and colon cancer.
Cowden causes colorectal cancer or polyposis?
Only polyposis.
Polyposis.
And Cowden's means?
PTEN. Chromosome 10.
Okay, fine. Is there any way that this, whatever Lynch syndrome and all, any chemo prevention that was advised? And there was a trial also.
Sulindac was used for chemo prevention.
Aspirin was used.
Aspirin was used. Sulindac for
aspirin trial was there. Okay, so for 10 years, if they use it, reduces mortality. That was what was proposed. So, what about prophylactic surgery?
CAP trial, madam.
Add aspirin trial. Okay. And what is the role of prophylactic surgery in hereditary colorectal cancer syndromes?
Prophylactic, if in case of FAP, where the number of polyps is more than 100, patients are usually advised to undergo prophylactic colectomy. If they and the timing of the surgery depends on whether if there is evidence of malignancy at that time, then the patient is advised to undergo prophylactic colectomy at immediately, the as earliest as possible. If there is any dysplastic changes or noted, then the patient is advised as earliest as possible to undergo prophylactic colectomy. And if there is profuse more than 1,000 polyps also, then the patient is advised to undergo prophylactic total colectomy as earliest as possible. If not, then the patient is advised to undergo prophylactic colectomy if it is not profuse or if there is no dysplasia of colon, whenever possible, immediately, without any time frame as such is not mentioned.
Around 20 years.
Yeah. So what colectomy you will do? Total colectomy, permanent ileostomy, or total colectomy with ileorectal anastomosis?
So that depends on...
In which case, the incidence of rectal cancers is high, and I mean, there are certain criteria. So incidence of, presence of those will mandate total colectomy with permanent ileostomy. So
yes, ma'am.
Total
So we have to first rule out if there is any synchronous rectal cancer present or not, if there is any adenomas in the rectum that is present or not, or if the sphincter or the continence is maintained and the sphincter function is intact. In those cases, if there is no adenoma, no polyps or anything, rectum can be preserved and an ileorectal anastomosis pouch can be formed and an rectum can be spared. But if there is a synchronous rectal cancer or a rectal adenoma, multiple rectal adenoma, more than 20, in those cases, rectum cannot be spared. In that case, we'll have to do a permanent ileostomy.
So, what about screening in those with hereditary colorectal cancer? How frequently will you screen? What will you, in this case, suppose take Lynch syndrome. So, what all will you see?
In Lynch syndrome, when we are Lynch syndrome, when we screen, we have to screen for colon cancer. We also have to screen for endometrium by doing a transvaginal sonography, and also CA-125 screening needs to be done. And we have to screen the upper urinary tract as well, which can be either by using a CT urinary tract, or a urine cytology needs to be done.
Okay, in contrast to normal people who do not have hereditary component, okay, so how, if it is it's a normal person, okay, who has got colorectal cancer, how frequently will you do colonoscopy? How frequently will you do sigmoidoscopy? Okay, and what is the fecal occult blood testing? So, can you tell me something about these investigations?
In a patient who doesn't have any known syndrome or anything, and no personal history of colonic cancer also in the past, then colonoscopy can be done once in every 5 years, or flexible sigmoidoscopy can also be done once in every 5 years, while fecal occult blood test can be done every 5 years, and this is starting from the age of 60.
I think it is 45 in average risk. Starting from 45, we have to do 10 years colonoscopy, 5 years fecal occult blood with sigmoidoscopy. It's like that, I think.
Sigmoidoscopy. Yeah, suppose colonoscopy is incomplete. Okay, there was
then within 6 months we have to do a colonoscopy post surgery.
Okay, then after that, when will you repeat colonoscopy?
After that, if it has a patient with a personal history of colon cancer, and if it was incomplete before this thing, then at the end, before 6 months, we have to do a colonoscopy.
6 months. Then
and
repeat
after
it?
that, every year.
Every year? I think it is every 3 years.
Yes, ma'am.
With the
And asymptomatic patient, it's 10 years, no?
Asymptomatic, it is 10 years. And with those with colorectal cancer, I think it is 3 years.
3 years, yes.
Okay. So, yeah, fine. Yeah, next, anything else? Family history we'll discuss in detail. Okay. Next, almost HNPCC and all that covered. Maybe variants of PAP and all we should discuss. We'll discuss in next class. Somebody else present RF mass and we'll discuss. Okay. Next page.
So I'll go with the general physical examination.
Yeah.
General physical examination. 44-year-old male patient.
And anything else, Drishita? Something, any medication history is important. Okay.
Yeah. Yes,
any blood thinners or anything. That one you must. And as I told you that any history of IBD in the past. Okay, with extra-intestinal. Okay. Next.
44-year-old male, well-built, moderately nourished, conscious, cooperative to time, place, and person with pulse rate of 80 beats per minute, BP 120/80, BMI was 20, ECOG score of 1, pallor present, no icterus, no cyanosis, no clubbing, no lymphedema or no lymphadenopathy or no edema. And coming to the systemic examination, on inspection, non-distended abdomen, umbilicus was central. All corresponding quadrants move equally with respiration. No dilated veins, no scars. Hernial orifices were intact. On palpation, no local rise of temperature, no tenderness. Solitary vague mass on deep palpation was felt in the right iliac fossa, measuring about 8 to 6 centimeter, with all borders were well felt. Surface was irregular. Consistency was firm to hard with restricted mobility, and mild tenderness was present, localized only to the area of the mass. No hepatomegaly or no splenomegaly noted, but on leg raising test, the mass was confirmed to be intra-abdominal. Percussion, no ascites, liver span was around 12 centimeter, auscultation, bowel sounds were present. External genitalia examination was normal. Rectal examination, sphincter tone was normal. Perianal skin was normal. Glove finger was stained with normal colored stools. No mass felt, no deposits. Left supraclavicular fossa examination, no lymph node felt. Spine examination was normal. Respiratory system, normal vesicular breath sounds heard, no added sounds. CVS S1 S2 heard, no murmur. CNS clinically normal.
So you missed few points in examination. So anyone can tell what she missed? Go back to your abdominal examination. Inspection. See, whenever you are telling, all quadrants will not move equally with respiration. First thing, okay? So, corresponding quadrants move equally with respiration.
All corresponding quadrants move equally with respiration.
Yeah, corresponding. That word is important, okay? So, hernial orifice is intact. Okay, fine. Anything next step?
Should we write scaphoid abdomen in place of
No. Scaphoid is not. She wrote, I mean, most of them accept non-distended. Okay? Though it's mentioned as normal abdomen, I don't think so. Any one of us have scaphoid abdomen. Okay? So, right. Yeah. So, tell me, what she has missed, or what?
One thing we can check for bimanual palpation and movement with respiration. She already told. Then retroperitoneal we can rule out by clinical testing.
All borders felt, you told. Okay.
Yes.
Right. So you told it's a vague mass.
Yeah.
Okay. First, you decide it's a vague mass or all borders are well felt.
No,
okay.
The thing I mentioned vague mass because it was felt only on a deep palpation. It was not felt.
And one more thing is that many of them will not accept this deep palpation. Okay, though it's mentioned, then what is superficial palpation? What is deep palpation? I mean, they ask like that. So just it is palpable or not. That much only. On deep and superficial, many of them don't accept. Okay, so when you tell vague mass, borders will not be defined. You cannot tell borders. If you tell borders are well felt, you have to tell where is the superior border, where is the medial border, where is the lower border, where is the lateral border. Okay, so all this have to be mentioned at the level of what. Okay, so how many centimeters from umbilicus it is there, medial to it, above it, below it. Okay, you can take a bony point instead of umbilicus. Is the distance from the umbilicus to the pubic symphysis same, or is it more compared to distance from xiphisternum to the umbilicus? Okay, the lower abdominal masses, there will be more distance between the pubic symphysis and umbilicus compared to this one. What?
Ma'am, I just have a doubt. That would be more in case of an ovarian mass or a pelvic mass rather than a RF mass is what I was thinking.
So if you only confined to right iliac fossa, may be right. Okay. Yes. But if it is extending into one or more quadrant, then I think the distance of mass should be important. Okay.
Yes. Yes.
So then yeah, borders. Can you tell the borders now? Like where was it exactly?
Inferior border was
in relation to ASIS. You can tell.
ASIS. Yes, ma'am. Inferior border was around 3 finger breadth, around 4 centimeter from the ASIS, while the upper border was around 10 centimeter from the ASIS, and width-wise it was occupying only the RAF fossa, not extending to the other quadrants.
Okay. What is medial lateral?
Medially, it was extending up to the mid-clavicular line, should I say?
You can tell in relation to mid-clavicular. 3 centimeters lateral to mid-clavicular line. Or
yes. So medial border was around 2 centimeter from the mid-clavicular line, while the lateral border was around 5-6 centimeters from the mid-clavicular line.
So whenever you are describing in relation to, whenever you are describing, so if you tell borders are well felt, you have to describe the borders.
Yes.
Okay.
Yes.
If it is not, you can tell vague. Okay. So these two things, whenever you are describing in relation to mid-clavicular line, how much below it, how much lateral to. Okay. So that way you can describe, or medial to, whatever it is. Okay. And or if you don't want to describe from mid-clavicular line, you can take pubic symphysis. Okay. So any bony point
also we can take, na? Iliac crest.
Iliac crest also you can take. Okay. Iliac crest you can take, but you have to tell mid-inguinal point or midpoint of inguinal ligament. That way it is. Okay. So and okay, you told surface is irregular, firm to hard in consistency. Okay. Yes. So what is firm? What is hard? Or you tell variegated consistency, you mean to say.
Yeah. But so the thing was, because it's on deep palpation, how can we comment on consistency?
That's what I'm telling. So you tell variegated consistency. So some people say there's nothing firm to hard. Okay. Either it is firm or it is hard. Hard is something like bone. Okay. Firm is
no stiff.
Yeah. And soft is lips.
Okay. Lips or your lobule.
Yeah. So that is the consistency. So if it is of different variable consistency, you tell variable consistency. Okay. So generally firm is accepted. Okay. Abdominal masses, no? Unless it's something very hard. Okay. hard is better not commented. Okay, firm mass is accepted. Okay, generally, what from colorectal cancers and all, you'll have that because of the impaction and distension of the bowel loop, you'll not have so much hard consistency. It will be firm. Okay, so firm is safe to mention. Okay, so restricted mobility where? Vertical, horizontal direction.
All the mobility was restricted. Like
all the mobility is restricted.
Yes. Yes.
Okay. Lower border is felt. Okay. So, and because DD of it's a male person. Okay. In a female, DD is still ovary can be there. So you should always tell lower border is felt. Okay. Okay. Leg rising, fine. What is the leg rising's name?
So that we know if it is arising from the superficial abdomen between the muscle layers or it is intra-abdominal.
Okay, you tell me what is the test for intra-abdominal mass, what is test for retroperitoneal mass, what is parietal mass test?
So basically on leg raising test, if the lesion becomes more prominent, then it is probably arising from the parietal mass. And if it becomes less obvious, then it is an intra-abdominal mass.
Then retroperitoneal?
Retroperitoneal usually doesn't change.
No. If it is retroperitoneal, what are the two tests?
Bimanually palpable and ballotability we'll have to check if it is retroperitoneal.
That's for kidney more so, but I'm not asking that.
Knee elbow and lateral decubitus.
Yeah, knee elbow and lateral decubitus. Okay, so that is the thing. Okay, knee elbow is not accepted by many, so you can do lateral decubitus. Okay. Then okay. So how do you examine for a liver and how do you examine for spleen?
For liver, if you are palpating, you have to start palpating from the umbilicals up to feel the lower border of this thing along the subcostal margin. While for spleen, we start palpating from the right iliac fossa across the umbilicus up to the left upper quadrant, hypogastric.
Okay. And what is liver span?
Liver span is measured on percussion. We start percussing along the mid-clavicular line, where the resonance of the lung is lost, and we start hearing a dull note.
Where do you start from?
We start around the fourth or fifth intercostal space and start coming down so that the resonant note of the lung weans off and the dull note begins. From there, we percuss till the lower border of the liver, that is palpable, or till the dull note again becomes tympanic note in the mid-clavicular line on the right side.
What is normal liver span in anterior, mid-axillary line, anterior axillary line?
Around 12 to 14 centimeters.
8 to 12, I think. Okay. And what about spleen you told? Next.
Next.
Anything you forgot? Anyone else? Very important for your case.
PR exam.
Loco-regional extent. PR you told. Any lymphadenopathy?
That's why the left supraclavicular fossa I've seen for.
Inguinal.
No, yet. Inguinal you are supposed to mention, right? Yeah. So always regional first, then distant. Okay.
Yes.
So though it's not the draining lymph node for this, but still, okay, you have to mention. Yes. Pedal edema, he did mention, I think, in general
physical examination.
Yeah, he did mention it. Okay, fine. Then, so what is your summary? Summarize your case.
Summarizing, a 44-year-old male patient with history of melena and pain abdomen with a palpable mass in the right iliac fossa. I would like to give a diagnosis of. I would still like to give a differential diagnosis at this point of right colon malignancy and a second diagnosis of IU sickle tuberculosis.
Yeah, in abdomen, always remember to give differential diagnosis. Okay, in abdomen, it's mandatory. Okay, so if you give a single diagnosis, then they won't accept. Okay, in abdomen especially.
Yes.
Okay. Next. So, how do you want to proceed?
I would like to get a ultrasound abdominal pelvis as an extension of my clinical examination to just confirm the organ of origin and also rule out if there is any mild ascites.
That's it. Anything else ultrasound will tell you in relation to colorectal malignancies?
I would also like to look at the status of the liver, if there is any hypoechoic lesion in the liver, and also.
It can give, though it's not very good modality, but it can give you a clue about regional lymph nodes. I mean, lymph nodes, lymphadenopathy. And
after this, I would like to follow it up with the CT abdomen and pelvis with plain IV and oral contrast.
Okay, fine. Anything else? So always again, I'm telling you, I'll do my investigations to confirm diagnosis, stage the disease, and for management. If you are telling in this way, you'll not miss. Otherwise, people will tell you'll not do HP, you'll not do LFT. So unnecessary questions, no? So not needed for discussion. So always divide. Okay.
Yes.
So
yes. So I would like to get ultrasound followed by CT abdomen and pelvis to confirm my diagnosis, and followed by lab investigations.
CT abdomen and pelvis will confirm your diagnosis.
Colonoscopy and biopsy.
CT will not confirm your diagnosis. Okay.
No, I think, ma'am, actually I had this confusion because in one of the ISO webinars it was given colonoscopy should be done before CT abdomen and pelvis. So,
yeah. The order of investigations will be always different, but that's why I'm telling. No, some will tell non-invasive, some will tell invasive.
Yeah.
But if you tell, what is thing that confirms your diagnosis? You tell me.
I think CT abdomen and pelvis because it's a mass in the
CT abdomen will give you pathological. It can still be tuberculosis.
Yeah, that's why I would like to do a CT first and confirm the mass.
No. Confirmation of diagnosis is through histopathology. Okay.
Confirm is tissue.
Confirm is tissue diagnosis. Okay. Anywhere. So suppose you in a breast case, will you tell mammogram will confirm my diagnosis? It will give a clue to diagnosis. But what will confirm your diagnosis for biopsy? Right?
But you do a mammogram before a court.
I'm not telling the order of investigations, ma.
Okay,
when you tell, I want to confirm my diagnosis, so what additional? Okay, we'll go it another way. If you do a CT, okay, will it only tell you about the lesion or will it stage the disease?
It will do both, actually.
It will tell about the lesion, extent, as well as the stage the disease. So, for staging investigation of choice, it is CT, not confirmation of diagnosis. Okay?
Yes.
Anywhere. Okay? Confirmation of diagnosis is tissue diagnosis. Okay? Right? Except in where tissue diagnosis is not required, like in HCC. Okay? Yeah. So, there, these markers and the lesion nature on imaging will give you a clue to diagnosis. Unless in those areas, your confirmation of diagnosis will be through histopathology. Okay? No need to have doubt on that. Okay? Okay. Tell me now. First you told colonoscopy biopsy. So, when will you not do a colonoscopy? I will tell in this case, I won't. Not in this case, but of course, so the patient
has signs of obstruction.
Yes. So in that, you'll not do a colonoscopy.
Obstruction or suspected perforation.
Yes. So Then what is the
I don't get it, madam. This question, madam. What we don't have to do colonoscopy. Emergency, na? That is emergency. We have to
obstruction. We cannot do colonoscopy because there are chances of perforation.
Inflate air, no, then it's a perforate. Okay.
So
whenever they do
after
colonoscopy,
operation, we will do after OT colonoscopy. One obstruction is relieved. If we are doing divergent stoma, in that case, if we are not doing divergent stoma, we are operating upfront. Then within 2 months, वो उसने बताया था.
Acute emergency case, acute emergency. But
any imaging, if it is giving you additional thing that helps you in management, you should do. Okay. So if it is not giving you a clue to management, then that imaging is not required. Okay. So in
colonoscopy is only in acute emergency setting, we should not do colonoscopy. Otherwise, if the patient is stable, we can do colonoscopy.
Yes, we should do colonoscopy. We should do.
Yeah. Only in acute emergency, we should avoid.
In obstruction cases, we should not do. Okay. So
if
because
the patient is in obstruction but is stable,
still if patient is in obstruction, you will not do.
But is stable. Say you are confusing with partial obstruction. Partial is and complete obstruction. Two scenario can be there. Partial is not like emergency. We can do.
Patient is having vomiting, not able to pass stool. Okay.
Yeah, that's so acute emergency cases. We should avoid.
That is obstruction. Okay, not an impending obstruction. I'm not telling. Okay, if it is in frank obstruction. Okay.
Yeah, that time we should not do.
Yeah. So what all you will see in colonoscopy? What is length of colonoscopy, Drishita?
1
colonoscope.
1.18.
Okay. And what about proctoscopy?
That 30 to 50 centimeter. Sigmoidoscopy, sorry. Proctoscopy is around 15.
So 12 to 15, 60 and 180. Okay?
Yes.
So what all you want to see in colonoscopy? So patient has done colonoscopy and come to you. So what are you interested to see in this case, suppose?
In this case, I would like to see the growth. We are able to cross across the lesion or not, and also rule out if there is any synchronous lesion anywhere else in the colon, or if there is any other polyposis or any polyps in the rest of the colon as well.
Okay, so
and if the colonoscopy has been complete or not.
Complete. That's what you can pass the scope beyond the growth or not. Okay, till the ileum. Okay, so fine. So colonoscopy, there's a growth in the ascending here right iliac fossa. So cecum at the junction of cecum and ascending colon. Okay, yes. Proliferative fracturing growth. Then the scope could not be passed beyond. Okay.
Yes.
There are no other growths noted anywhere else. What is the instance of synchronous malignancies?
10 to 12%.
No.
5%.
3 to 5%. Okay. Then what about what is synchronous? What is metachronous?
Synchronous is at the time of the diagnosis or within 6 months if you notice a lesion along with the diagnosis of the primary. Metachronous is after 6 months.
Okay, fine. So suppose you tell me in two case scenarios. In this case, only single lesion. There's another lesion which is there in the mid-transverse colon along with the ascending colon growth. So in these two, how will you plan?
In both the cases, first I would like to get the biopsy and also try to get the IHC and also the molecular testing, considering him to be a 44-year-old male patient presenting with a CA colon. Followed by, I would like to get the staging done, staging investigation done. which would be your CT thorax with CT abdomen and pelvis with IV oral contrast to look for the local extent of the lesion as well as the regional lymph nodal status, and if there is any distant spread, especially most commonly into the lung.
Okay, what all we'll discuss about CT. I forgot one point. What are the presentation differences between right colon and left colon? And history wise and the clinically, I mean the
left-sided colon usually presents with obstructive symptoms. So being constipation, altered bowel habits, spurious diarrhea, bleeding per rectum, while right-sided colon are less obstructive presentation and their non-specific symptoms or anemia, melena, with altered bowel habits being the most common.
Generalized weakness, melena, anemia, all those things. What is the nature of the growth in the right colon and left colon?
Right colon is more of a proliferative growth, while the left colonic is more of a structurous growth.
Okay. Any other differences? Which is better, right or left?
Left.
Early advance according to early stage.
You know the answer. Just think a bit.
Right side colon is better than the left side.
So right presents early or late?
Left presents early, right presents late.
So
left is better.
Left is better because they present early because of the obstructive symptoms. Okay. Whereas right will present in advanced disease. Okay. So their symptoms are very vague. Most often, we all see, that they'll be generally evaluated for anemia. They'll be giving supplements. They'll not do scopy anytime. Okay. Finally, they'll end up with some fixed mass there. Okay. Big lymph nodes. All that things. Okay. Fine. So now, where were we? Yeah, colonoscopy, we finished. Any other investigations?
Pre-op CA levels.
Is it CA? Yeah, tell me something about CA. CA prognostic, diagnostic.
It's a prognostic marker with significance more post-operatively rather than pre-operatively in follow-up.
Yeah, it's for comparison rather than pre-op levels.
It is prognostic also. Elevated pre-op CA is one of the adverse factors, and second, it is used for surveillance. If the patient has drop in post-op CA, and then it is a useful marker for following the patient.
Especially very high, like more than 200, then it will be useful for prognostication.
So what is the measurement and what is the unit for CA measurement?
Nanogram per ml.
Okay, what is the normal limits?
Less than 4, 1 to 4.
5, greater than 5 is considered significant.
Anything with smokers, non-smokers?
Smokers, it can be elevated.
Smokers, I think 9 is normal. Up to 9.
Up to 4 they consider normal. Okay, so anything up to 5 to 7 in non-smokers, smokers is at, the higher range. Any other things? What are the cancers which don't have CA increase?
If it is signature cell type or a mucinous type, then the CA might not be raised.
Poorly differentiated.
Poorly differentiated.
Mucinous also. Okay. Correct. And what about any other things in blood investigations? First, we'll discuss. What is the important?
Chemogram, we'll have to get it done because it's a patient presenting with a history of melena. So the HB level becomes an important factor. Along with that, even the liver function test to look for any altered liver function or even albumin status to know the nutritional status of the patient. And other than this, has serum electrolytes and renal function test as well. along with serum tumor marker CA.
Okay. So, an image in colonoscopy is a confirmatory investigation. Anything other than in imaging? So, tell me, okay, in colonoscopy, any adjuncts you can use, suppose, to detect
lesion. Or virtual colonoscopy, we can say. Virtual colonoscopy.
Capsule colonoscopy.
We can use something chromoscopy or something in narrow CT.
Yeah, you can use dyes. Okay, so to detect, and NBI can be used. Okay, so and any in what do you mean by CT colonography?
It is a virtual colonoscopy where CT is done and there is 3D image reconstruction to give a virtual image of the to give a virtual colonoscopic like image.
Yeah, correct. You're correct. Okay.
It is actually a CT depiction of mucosal deformity in the colon, where dye is used.
Give you the mucosal pattern picture through a CT. So that's
it is as equivalent as colonoscopy to detect the mucosal lesion.
Yes. So
and if anything is abnormal, we have to confirm by colonoscopy now. If like
yes. You have to. So what about now CT? Okay, you want to use contrast or plain image?
With plain IV and oral contrast as well.
Okay. So what do you want to see in plain? What do you want to see in oral and IV?
One I would like to see in plain is localize the lesion, anatomical location of the lesion, from where is it arising from. But I would like to have IV contrast to delineate it better in relation to the surrounding structures, local extent, relationship to the blood vessels, nodal extent as well, and oral contrast to know the mucosal extent or the colonic extent of the disease.
So, and IV contrast is important for detecting any abnormal lesions in the liver.
Liver as well.
So again, same thing: local, regional, distant. Okay. So local extent. Okay. And in addition to that, this one regional lymph nodes, distant liver and ascites.
And
ascites. You can get something about omentum thickening and all, but it is difficult. Okay. So then was there any trial that compared colonoscopy with CT colonography? Anything that you are aware? CT colonography with colonoscopy. So it is SIGGAR trial. SIGGAR, SIGGAR trial. Okay. So
that is for screening.
CT colonography with colonoscopy, it has compared. Yeah, in screening only. Okay. Yeah. Next, CA, you told me. What is the abnormal rise in CA apart from colorectal cancers, where all it is raised?
It can be raised in any inflammatory colonic disease. It can also be raised in any peritoneal inflammation. Even in ovarian malignancies, also we can have a raised CA level.
So IBD, COPD, peptic ulcer diseases, gastritis, all these cases it can be raised. Okay.
And upper GI malignancies.
Yeah. Upper GI malignancies also, yes. So is CA independent marker, like independent prognostic marker, pre-op CA?
It is a prognostic marker also. Pre-op elevation of CA is one of the adverse factors of prognosis.
Yeah, significantly elevated CA, as you told. more than 200. So that will almost always they'll have metastasis. So that is then anything for distant metastasis other than CCT abdomen.
There is, it is CCT chest, abdomen, and pelvis. Chest is to be included.
Why CCT? Chest.
Chest, we can do HRCT also, non-contrast also, but if we are doing a single investigation, we will be doing CCT of chest, abdomen, pelvis, or another option will be to do X-ray chest and CT abdomen and pelvis. But the more logical this investigation will be to do combined CT, chest, abdomen, and pelvis, but chest has to be included.
Yeah, I mean, HRCT chest would do. Okay, no need of any contrast. Okay, so it will detect metastasis. So where are the metastasis from colorectal cancers more common? Colon cancers and rectal cancers.
They're more common in the liver being the first site, next being the lung, and then the retroperitoneum.
Peritoneum.
No, how does is there any difference between colon cancers, rectal cancers?
Lower rectal.
Rectal cancers, they have more incidence of liver mets. Colon cancer has more incidence of peritoneal and distant mets, non-hepatic mets.
Okay, rectal cancers have more incidence of liver mets. Okay, so yeah, now can you tell me the staging? Yeah, next, this is the staging investigation, right? Any other investigations you want?
No, ma'am.
In your case,
in case of suspicious liver lesions, we can do MRI liver, which is more sensitive and specific for liver imaging. Or in case of inconclusive findings, we can also do PET. But routine role of PET is not indicated.
When is PET indicated in colorectal cancers?
When there is a recurrent, if it's a recurrent disease, or if there is an equivocal CT finding which is in discordance with the clinical finding, only then PET is indicated. Otherwise, as such, in a primary colon cancer, PET is not in.
Okay. So, any this one, what PET MRI? Anything? That's it, no investigations. Yeah. So now, how do you want to proceed? Rectal we'll discuss later, okay? Staging. First, you tell me staging.
So, should I tell of my this patient? So,
I mean, you have images or anything?
No, that was an OPD patient actually. Nothing has been worked up yet.
Okay, fine. So, okay, I'll only ask you. So, if there are deposits in non-peritonealized areas, so what is that stage?
It is T3 if there is infiltration into the non-peritonealized surface of the colon, like if it is extending into the omentum non-peritoneally or into the retroperitoneum, it is T3 only. Extension into the peritonealized surface will be T4.
Omentum, like omentum is.
Okay, Drishita, you tell me staging complete.
T1 lesion is when it is extending in, first it is intramucosal, where it is not reached up to the submucosa. When it is reaching up to the submucosa, it is T1. When
T1 is submucosa only in colon.
Yeah, T1 is only submucosa. There is TA and T1. Sorry, first one what I said was intramucosal, that is TA.
TIS, carcinoma. TIS, mucosa only, T1 mucosa submucosa not extending into muscularis, T2 muscularis, T3 subserosal, and T4 serosa. Then T4A and T4B.
Okay. Yeah, you're correct. You tell. N.
Oh,
N staging.
And N1 is there is N1A, N1B, N1C. N1 is 1 to 2.
1 to 3.
1 to 3.
1 to 3. And 2 is
4 or more.
4 to 5. And
N3 is any lymph node which is along the mesovascular trunk or metastasis to the apical lymph nodes. That is N3. M0 is no mets, and M1 is with distant mets. So stage 1 is T1, T2, N0, M0. Stage 2 will be T3, T4, N0, M0. And stage 3 will be, again it is T1,
NET,
T2.
NET, N plus.
Yeah, node positive will be stage 3, and stage 4 was with mets.
Yeah, correct. So now, yeah, you tell me, in your case, you have done investigations. There's a single lesion, okay, with few. What are the lymph nodal stations in colorectal cancers?
Epicolic lymph nodes. Then there is intermediate lymph nodes, which is along the vessels, and then there is apical or the principal lymph node, which is along the major vessel. That is usually
epicolic, pericolic.
There is
paracolic, intermediate, and the principal lymph node.
Central.
Principal. Main vessel, principal.
Yes.
So yeah. So what is the difference in that? Japanese resections and our resections, like how do they consider? So, can you tell me what is D1, D2, D3?
Yes.
Lymphadenectomies, and what is the difference in resections that Japanese do and that we people follow?
So basically, it is the CME and CBL resection that has been described, and in which again the D1, D2, D3 has been described individually. D1 is along is the vessels which includes epicolic and the paracolic lymph nodes. D2 when it includes the blood vessel, the intermediate lymph nodes reaching up to the root of the SMV or the surface of the SMV, that is D2. When D3 is when even the SMA or the surface of the SMA is also exposed, that becomes D3. So in Japan's classification, they include D3, while overall otherwise it is D2 that is being followed. And also in the length of extension of the colonic specimen, we include 10 centimeter on either side. But the Japanese study, they include either 10 centimeter on either side of the principal vessel, or if there are two vessels, then 5 centimeter on the either side.
Yes. So they follow the vascular pattern rather than like gross 10 centimeters on either side types. Okay. And the in front of the major vessels also they go and remove clearance.
Yes.
Okay.
Yes.
So okay. Next. So in this case, what do you want to do?
With a single lesion noted only in the ascending colon, and no other liver mets, peritoneal mets, or any other metastasis, considering it to be resectal, I would counsel the patient first for an upfront surgical option, being right hemicolectomy with D2 lymph node resection.
Okay. So what about this one? Any role of neoadjuvant therapy? Any studies?
Foxtrot trial is one of the study which studied for role of neoadjuvant chemotherapy, but
it's a negative trial, or
it's a negative trial because considering the primary endpoint of was not reached. There was no much response that was noted, and they included
what were the drugs used?
They used 5-FU and oxaliplatin.
Correct.
And panitumumab.
Sorry?
Plus panitumumab.
Yes, one.
Panitumumab.
Yeah. In one arm they use panitumumab also.
Folpox, no?
I remember only 5-fluorouracil oxaliplatin.
3 arms. In one arm they use panitumumab. I'm not.
No, that is Protege 22.
No. This only Foxtrot only.
Foxtrot had only 2 arms.
I think in one arm they use panitumumab. Correct me. I have read a lot.
No. Foxtrot was only 2 arms. In one arm they used 6 cycles Folpox first, surgery, and 10 again remaining cycles of Folpox. Other arm was surgery and followed by distant chemo.
Even I remember I used only 5-fluorouracil and oxaliplatin, and there were
somewhere a photo is there that panitumumab in third arm. Okay, we'll check, madam.
I'll check.
Maybe I might be wrong.
They tried this immuno, but it not showed any results.
Yeah, they tried panitumumab in one arm. We'll check, madam. Maybe I might be.
Yeah, we'll check. Okay, no problem. So, fine. Then, okay, no role of neoadjuvant chemotherapy as such now. Okay, any role of immunotherapies?
Immunotherapy, the recent trial, the Initiate-2 trial, showed that in deficient MMR patients, nivolumab was known to have a significant tumor downstaging and the response rate.
Yeah.
And improve in survival as well.
Disease-free survival. And okay, so that's about So next, what are the types of resections? And what vessels will you take?
The standard being the complete mesocolic excision and with the central vascular ligation. In this patient, I would like to take ascending colon lesion. I would like to take the right colic and the ileocolic vessels.
Okay, CVL is standardized now?
It's institutional practice, but we do follow central vascular ligation.
You do follow, but initially it was told that CVL
is associated with increased intraoperative vascular injuries is what is one of the criticism against CVL.
So there is not much benefit.
CVL should be standardized. There is no increase in the operative time. There is no significant morbidity. There is increase in the lymph node yield. The lymph node yield has been seen as a prognostic in both N0 disease, that is stage 1, stage 2, as well as in stage 6, that is if nodes are positive. So CVL or
your lymph nodal clearance will not depend on central vascular ligation. Okay, you have to go and remove the lymph node. You need not.
High clearance, low ligation at our institute. So
yeah, that is followed now. Okay, because the lymph nodal clearance is immaterial of where you ligate it. Okay, so low ligation is preferred compared to central vascular ligation. Okay, and the lymph nodal clearance has to be complete up to the main vessels. There is no doubt. Okay, and your lymph nodal clearance will not be increased in CVL. Okay, so it's like if you clear the lymph nodes up to the main vessels but ligate it low, still you get the same lymph nodal yield. Okay. Then what is some complete mesocolic excision? What is mesocolon?
The mesocolon is basically it's complete mesocolic excision is just the extension of the TME that is followed in the rectum, where the mobilization of the colon is done in the embryonic plane that is covering the rectum, including the mesentery.
Okay. So it's same like TME, correct?
Yes.
Then any role of RT?
There's pre-op RT. There's no role at present.
R plus resection. Post-op RT is used only in the R plus resection. Otherwise, no role.
Yeah, still it has a lot of bowel effect on bowel. So generally it's not standardized post-operative. Okay. So then what else I should ask? Adjuvant, anything targeted therapies?
Adjuvant has such targeted therapy is more of in a metastatic setting rather than in stage 1, 2, or 3, where either bevacizumab is used, but they're more preferred in a metastatic setting.
Yeah, it's in a metastatic setup, correct. Okay, any trials which told about this diet, obesity? Or fiber diet, something. I'm giving you a clue. Anything which told you about increase in fiber content in dietary, this one will reduce the incidence of colorectal cancers, which was a accent collaborative group study. Okay, so whenever there is increase in fiber in diet, there will be less exposure of carcinogens. Okay, so
the stasis time will be less.
Stasis time. Yeah, so that is, and so what else? Blood transfusions and colon cancer. What do you know about that?
Blood transfusion is a negative prognostic indicator. Blood transfusion is usually immunosuppressive. It acts as an immunosuppressive agent. There is increased risk. There is adverse prognosis if blood transfusion is used.
So there was a study before. That's very old study. Okay, it was done in 1996 or so. Okay, so wherein they have seen that the patients who, when we have transfused blood, okay, preoperatively, they have done bad, and they have stated that it will lead to more of metastasis at a later date. But over time period, that they have told that this is not the way. Means this is not what they have proposed. Is correct, because those who required blood transfusions were in poor general condition as such, and they were in advanced disease. There were many other factors that contributed to those patients developing metastasis rather than the requirement of blood transfusion as such. Okay, so this was stated in follow-up study. I forgot the name of the study. I'll tell you tomorrow. Okay, so I forgot the name of the study. So yeah, so can suppose it's presenting with mass only, Drishita.
Yes, ma'am.
So can you give me some differential diagnosis? Mass, pain, no altered bowel habits as such.
Right iliac fossa mass. Then it could be retroperitoneal mass.
Okay.
And we would have to, in males, we'll have to check for if there is any undescended testis as well, because it could be even be a testicular mass.
Okay.
And other than that,
yeah, that's most common. Okay. So
then, can be
sorry.
Amoeba.
Amoeba. Okay. Yeah, it can be amoeba. Correct.
And psoas abscess as well.
Yeah. So as sepsis, they present more of with inflammatory issues. So pain, fever, and all those things were present. Okay. So in what else we have discussed? Yeah. So can you tell me adenoma carcinoma sequence and what is the name?
It's called Wong-Easton.
Pearson-Vogelstein hypothesis.
There are two pathways for colorectal development, from normal mucosa to adenoma to carcinoma. One is CIN pathway, and another is MMR pathway. CIN pathway which is most commonly seen in around 70 to 75%, and MMR pathway is seen in around 20 to 25% pathway.
I mean, now it's like four
three pathways.
CIMP.
There
are two pathways.
talking about the molecular classification of colorectal cancer, I suppose.
Yes, ma'am.
Yeah.
CMS. That is what he's talking, na?
CMS,
No, I'm asking the changes. What you told is that early adenoma, intermediate.
The pathway to the development from normal mucosa to adenoma to carcinoma, it is broadly divided into two pathways, CIN pathway and MMR pathway. In MMR pathway, there are two pathways. One is MMR deficient pathway, and another is methylation of MMR genes. But broadly, there are only two pathways.
CIMP is also there, na? CIMP.
That is CIMP. That is methylation of MMR genes. That is also
not always. Not always. No, it has two parts. Like where will serrated polyps go then? Serrated polyps.
Some books write 4 pathways also. Like we have 4 subclassification. One is this pathway FAP. One is CIMP. One is MMR. One is inflammatory. Inflammatory is for ulcerative colitis.
Mesenchymal type.
Yeah, there are four subtypes. Molecular 4 pathways also. Some write, but broadly 2, 3 we categorize.
I'm asking you only the simple thing, okay? So what are the genes from? Yeah. What are the genes that are associated with formation
when there is a normal colon, the first being the APC mutation, which makes it into dysplasia. From there, it develops into an early adenoma, which is again APC and beta-catenin. From early adenoma to intermediate adenoma, and then into a late adenoma, where it is KRAS comes into picture. And from there, KRAS and BCC. BCC is MAD4. And from there, in the P53 mutation, which makes it into a change into a carcinoma.
So, okay. And so, what this you told me about CME CVL, no?
Yes.
So, who were the people who told about this CME CVL? Any idea?
Werner
Hohenberger.
Yeah. So
T-Rex
what is
study?
Sorry?
T-Rex study. D1, D2, D3.
Yeah. Anything else that we have left?
Minimal invasive in
Adjuvant
Tell me about
therapy
the minimally invasive. Yeah. Minimally invasive and follow. Both you tell.
Minimal invasive is basically 3 trials, major trials. That is MRC Classic, Color Trial, and PAUSE Trial. All trials have proven that MIS was associated with better short-term outcomes as well, and also better short-term outcomes, and the long-term outcomes, as in the oncological outcomes, were similar in minimally invasive and open. So right now, MIS is the standard of care. But all the 4 RCTs excluded T4 tumor, perforated tumors, and obstruction.
So for these tumors, you can do
robotic.
There is presently no RCT, but it is extension of the laparoscopic versus open surgery in the color trial and classic trial. As such, there is no direct randomization trial which shows evidence for robotic.
In rectum it is there, no? Roller. And what about minimally invasive erect? And follow-up, you tell me.
Follow-up, basically, if the patient has undergone a complete colonoscopy prior to the surgery, then we need not do. Otherwise, we have to do a repeat colonoscopy at 6 months Other than that,
Hmm.
patient should every 3 monthly ultrasound abdomen, CA, and a clinical examination is done for the first 2 years, and after that, every 6 months from the third year to fifth year onwards, and after that, annually it is done.
Yeah.
And
imaging and investigation if patients showing any
develops
symptoms.
Any
And
any
if CA
suspicion.
level on rising trend, then we will go for PET scan.
Acha, how many CES you will see? Do you do serial follow-ups or?
on every follow-up, we
Abhi ek hai. Yes. So you operated, okay?
yes, ma'am. Yes.
CA first one was 6, okay? So then what you want to do? First post of follow-up.
First of follow-up, only CA is 6 and no other symptoms or anything. Based on the pre-op CA, we have to compare. If it has dropped, then we
How
just
much time you'll repeat CA again?
after 3 months.
If CA is on rising trend.
If it is borderline, it is not significant, very high. It is borderline rising. We will again repeat in 3 months and see the rising trend. If it is settling, not rising, or it is in borderline only, then we follow. If it is rising, then we may proceed with colonoscopy and CT.
So suppose it is 6. Next, she repeated. Okay, 2 to 3 weeks. Close follow-up. Okay, if it is rising in the rising trend, suppose it is 15. Okay, double. Then how many will you see before taking a call on doing a metastatic workup or workup for recurrence?
If 50, then ma'am, there's no doubt we have to go for metastatic workup.
With a single or
at least 2 to 3 readings of persistently rising CA level. In that case, we have to plan for a metastatic.
Yeah, it is minimum of 3. Okay.
So if it is more than 10, then also, ma'am. It's like
no, it's not
5 to 10.
It's not about more than 10. It's not about more than 10 or less than 10. If it is in the rising trend, अभी 10 देखा है, next में 20 देख रही है, okay? So next में 50 देख रही है. So definitely you'll do. Okay, it is in the rising trend.
Ma'am, we have to. Ma'am, what is the interval for repeating? For say, for example, if it is
3 weeks. 3 weeks. Okay.
3. Okay.
2 to 3 weeks. Okay. If it is in the, if you after you have operated, okay, if you have done a pre-op CEA, okay, if you have found that it is the post-op first CEA is more than the pre-op CEA, then keep them under close follow-up. Okay. So repeat it after 3 weeks and then see. If it is in the rising trend, more than 3 values, get a imaging done or get the scopy done, whatever. If that's symptomatic and all, metastatic recurrence as well as metastatic workup. Okay.
Role of HIPEC in CA colon.
Yeah, what is the role of HIPEC and what are the trials?
HIPEC, it can be either prophylactic or as a therapeutic. In therapeutic, there is a trial product 7 which showed if the PCI level is between 9 to 11, then achieving a complete cytoreduction and HIPEC is beneficial. But if it is more than that, then the HIPEC doesn't have any much role unless a complete cytoreduction is achieved. While for prophylactic, it is not proven yet. Various trials like ColoChip, Chipol, these are
ColoPac and HIPEC T4.
Yeah,
HIPEC T4 अभी आया है.
Prophylactic?
Prophylactic में ही है मैम.
Prophylactic is ColoPac and HIPEC T4.
Okay. Anything else?
Stage 2.
Trials of adjuvant therapy, ma'am.
Yeah, tell me. So, okay, first, when will you consider in stage 2 of colorectal cancer? So, what are the indications for adjuvant chemotherapy?
So, we'll have to look on various clinico-pathological features, like if the patient is MSI stable, or it was an obstructed or a perforated tumor the primary stage 4, or there was an LVSI or a poorly differentiated colon cancer, then in those cases, the benefit of chemo is up to 5%. But still, and in patients who do not have any adverse factors, the benefit of chemo is only 3%. So we'll have to decide with the patient and consider the comorbidities and everything, and then consider chemo.
Any role of MSI and MR testing?
If MSI is stable.
In stage 2, if it is MSI high, so there is no role of adjuvant chemo in the presence of adverse factors.
Okay. And MSI high के लिए क्या दोगे?
MSI high, we do not have to use a single agent. Folfox नहीं देना.
No, we just observe.
Observation.
In stage 2.
Stage 2. Okay. So otherwise immunotherapy. Okay, it acts better. And what is the, okay, you already told, I think, what is the drug that was not beneficial with MSI high?
Folfox. Single agent Folfox. Single agent 5-fluorouracil.
5-FU. Okay. And adjuvant RT no role. Okay.
Mosaic study is also saying, no?
What?
Mosaic study.
Mosaic
study. Okay. Anything else that we left over?
In
okay, doses बोल दो.
New NCCN, they have given different drug, I think, for MSI, जो adjuvant treatment, but it is for rectum only, not for colon, no? I don't remember.
Oh, so the trials of adjuvant chemotherapy, they are actually for colon only. So in rectum, they have been explorated from the colon. So actually there is no such adjuvant trials in rectum.
In starting, when we are doing MSI testing, then in starting, in rectum cancer, they have given some different drug. That is dostarlimab or something.
Dostarlimab. There was that study, where 12 people have achieved complete CCR, complete pathological response. So they were just observed.
So
okay, no, that was in rectum, not in colon.
Adjuvant setting.
Neoadjuvant setting.
Neoadjuvant setting में जब दिया था तो complete response आया था. There was no tumor in 12 people. So, but it has to be done in long term. Follow-up is required, and large number of patients are required. So, though it was considered one magical drug, but still we cannot guarantee that everyone will get that complete response.
So, in upper GI means stomach and esophagus. Now they are doing MSI testing upfront, and they are putting the role of neoadjuvant treatment with this MSI testing.
Yeah, they are adding nivolumab. No, it has come in esophagus and stomach.
And stomach also they are saying that after complete response we can observe. That was shocking for me to see in NCCN, but it was like that only.
After complete response, recent one trial has come, where nivolumab, if you get complete response, again it depends on whether it's adeno or squamous, and what has been given before. What is the treatment given before? Recently only that article has
will come. In dysphagia can come in exam.
It can come, Ray. I am telling if you get a center where patient caseload is not there, they can keep all odd cases. It's for discussion purpose. अभी एक सोचो कि कुछ भी post Ewing's रखा था, means response के साथ chest wall tumor, कहाँ वो बॉम्बे हॉस्पिटल या कहीं पे रखे थे. So just for discussion purpose of chest wall tumors, they didn't have cases. So that's why they will sometimes, if they don't have cases, they'll put some odd cases. But generally, see, one breast, one oral cavity will be there. Without that, no exam. So oral cavity also, unless they're sadist, they won't put larynx or hypopharynx, oropharynx. ये नहीं रखते हैं. Surgical oncology exams में. That's it. Then you will have one mass abdomen. Typical thing is one mass abdomen if it is there, or one soft tissue sarcoma will be there. Definitely.
OJ
So
can be there.
Mass abdomen में RCC आ सकता है. One of you present RCC. RCC is important. Okay.
OJ.
So OJ, if you get centers in north, OJ might be there. South में इतना common नहीं है. आता है तो गाल ब्लैडर आता है. ओजे से प्रेजेंटेशन साउथ में कॉमन नहीं है, साउथ सेंटर्स में. नॉर्थ में यस,
हम लोग के यहाँ तो it's very common.
Yeah, I'm telling that only. I mean, north and northeast, or is this? You are in Patna, no? That is. So here in south centers, it is difficult to get OJ. Okay, but if you get OJ, it is good because you'll score more. That is. Okay.
Thank you.
That's it, I think, in colon.
Thank you, ma'am.
Yeah. Okay.
Good night,
Fine.
Thank you.
Yeah. Okay.
Thank you very much.
Bye. Bye.